So, good evening, everyone. I am Simran Siraj. I am the communications lead for AI-Sarosh, and I welcome you all to this important conversation on adolescent sexual, reproductive, and maternal health and the role AI plays in evolving access, trust, and care. Today's session is part of AI Sarosh, a regional knowledge hub co-led by PHC Global in Pakistan and GTA Foundation in Nepal. It supports ethical, tailored, and culturally sensitive AI solutions for sexual, reproductive, and maternal health across South Asia. This work spans across Bangladesh, Nepal, Sri Lanka, and Pakistan. And the beauty of this journey lies in how deep rooted it is in local needs and community experience. Our Inside the Project series aims to highlight the nine AI innovations that are working on sexual, reproductive, and maternal health issues across South Asia through AI Sarosh. Through these conversations, we are spotlighting projects that are designing locally rooted solutions that share emerging lessons and build a regional community of practice that is dedicated to ethical AI advancement in sexual, reproductive, and maternal health across the region. In today's episode, we're delving into a very innovative approach to maternal health care using AI technology to enhance fetal ultrasound services in community healthcare settings in Nepal. I'm thrilled to welcome our guests from Nepal Applied Mathematics and Informatics Institute for Research, NAMI, Dr. Bishesh Khanal, the research scientist and director, and Kanchan Poudel, the machine learning researcher. Welcome to both of you, and thank you for making time to join us today.
Thank you. Thank you very much.
We will be structuring today's episode around three key themes. The first will be the challenges in providing quality maternal health care and fetal ultrasound services in remote and rural settings. Second, how AI can bridge these gaps through innovative solutions that are tailored to resource constrained environments specifically. And then the third will be on how ethical considerations and community engagement is needed to ensure that these technologies actually serve local needs. So when you both are ready, we'll keep this conversational and I'll be asking you questions and you can take turns to answer. There will be questions addressed to individually. And then even if I'm asking a question to just one person, the other can also answer. Um, that's great. That's good to go.
Yeah,
Okay. So, Dr. Bishesh, let me start with you. What are the critical gaps that you see in fetal ultrasound services across Nepal, particularly in rural and remote areas? And how do you think these gaps affect maternal and child health outcomes?
thank you. I think one of the very important tools or important device that is used during pregnancy to look after the fetus and is ultrasound, medical ultrasound. That is a imaging device that is radiation free, so it doesn't harm doesn't have any harmful radiation, and we can look inside the mother's or the pregnant woman's womb, fetus, and this is used typically by radiologists in most settings in the world. Who takes the probe, ultrasound probe, in their hand and goes into important areas of, so for example, in fetus's head, in brain, in heart, in abdomen, femur, different parts of the fetus and the different parts of the uterus to look into how how the woman, how the pregnancy is happening. And but the problem in Nepal and in many other low-income countries or in general resource constrained settings is the radiologists who are the experts are not always available in many places. While the ultrasound devices, which used to be very expensive in the past, which is more portable recently in the last decade, and in the recent few years, it is even handheld. So it's almost the size of smartphone. You have a probe that is size of a smartphone, and then you can attach this into a smartphone or a tablet. So with this, you can look into the human body with the ultrasound, and this is getting cheaper and cheaper. With almost $1,000, we can see a future in a very near future. It's going to maybe $500 or less. So on the one side, we have this very promising opportunity that these devices can go to almost every place in the world. being very cheap and being handheld, but then you would still need the expert to use this ultrasound device and look into the pregnancy. And this is where the challenge lies, and this is exactly where AI has the unique opportunity to help solve. Is in countries like Nepal. Nepal is relatively well known in the past few decades on their very strong community-based healthcare program, where they have nurses, community health workers who go and reach out to the community to monitor or to for the ANC, or the antenatal care on this care. This is something that has been very good, which has helped reduce maternal mortality rate and the infant mortality rate in this part of the world. And it is taken as an example. But access to ultrasound service is still a challenge because of the lack of radiologists. And the government of Nepal has built a rural obstetric ultrasound program where they train nurses to do the ultrasound in a simplified way, but only limited. But then they can only look at very limited things because they are trained for a very short span of time, as against radiologists who would have trained for a very long period of time, right? But this is still better than not having anything. That was the idea with which they did the rural obstetric ultrasound. But then again, the challenge with this kind of what we call as task shifting in public health, where instead of the expert radiologist, you are using nurses to do a reduced form of the test. There are three key problems. One is now the people who are in resource constant settings, they are getting ultrasound care, but still less than a person who is privileged or who is in the proper settings, in urban settings, or who can get the radiologist care. They get better care, right? So that's one problem. So by the definition of task shifting, they are getting reduced care, and which is not equitable. The second problem is the nurses or the community health workers or whoever is doing this. We need to regularly monitor the quality, and there's always the questions about how good these are. And it's hard to scale this kind of thing unless we can regularly monitor. But then for monitoring, again, you need experts. The third is the training component, where every new person, every non-expert comes with a very short period of training. It's hard. So, and this is where AI comes in, when we have this handheld, low-cost ultrasound that can go everywhere, and the non-expert who can routinely do this kind of scans in most remote parts. Now we are augmenting. We aim to build AI system that on these handheld systems, when used by non-experts, can work potentially as good as radiologists would be doing that with this. So that's the core idea, where then uh, almost all the pregnant women would be able to get the ultrasound care, which is crucial during the pregnancy to monitor the pregnancy. And if there is certain important conditions, situations, then they can refer this to higher centers, secondary centers, health centers, or tertiary health centers to pick these problems early and monitor this. So it's about democratizing ultrasound access everywhere in the world by enabling non-experts to do very high quality ultrasound with extremely simplified protocol, where they don't need to get trained on too many complicated things, but with AI that can look into all these important things that typically a radiologist would look into.
Thank you for sharing that, because this just tells me that you're not only making the ultrasound more equitable and accessible, but you're also training. There's also capacity building component to it, where non-experts are also learning a new technology and also helping the community in ways that they couldn't before. Um, so thank you for that. Kanchan, from your perspective, as someone who's working on the technical implementation of this project, what specific technological barriers do you think that must be overcome to make AI-powered ultrasound services accessible in these community health centers?
So the first thing I think is the people who are going to be affected by this. We need to make them understand about the technology itself. That's one thing. And second is that like just making the devices and operators go to those centers is one thing, but then like those remote areas are also kind of places where people are not used to like getting screened early, or like go for medical follow-ups. So like making them like adapted with that, and then like making them aware about they should not be afraid of the condition that's getting diagnosed or screened. Rather, it's good for them to get screened early, and then like they can access the service. So like making them not lose the follow-up and things like that is one thing that's important.
Technical, I think it's also, what are the technical barriers to build this kind of system in terms of AI? What are the things that needs to be done?
So technically, like once everything is built, like we are targeting resource limited like places and areas like that, but it does take some resource on our end to build systems like this, the computing resources and everything. I think that's one barrier.
Yeah, and just to add to Kanchan, I think it's also in terms of the AI models, because what we are using is extremely simplified protocol, which we will explain perhaps later, and what we call as blind sweep protocol. And with this kind of images, we don't usually see typically specific images that radiologists are trained to see. So we get this information, partial information about fetus in many different images, and there's multiple videos where this information is scattered, and how to very accurately and robustly interpret these videos to get results or predictions as good as radiologists, that's still an open problem in AI. I mean, for certain specific cases like gestational age or fetal presentation, this has been, I mean, extremely promising results have been shown, but there is still some some distance to really show that this works across different populations, across different handheld devices, and this is consistently as good as in the real settings. It would really benefit the patient. So these models, AI models that are good enough, robust enough, that can really help help in the settings where we intend to help. These are still in research phase and the translation. So this is the technical challenges are also on building these robust models, AI models that are really good. Yeah.
Thank you, because I think you just mentioned that training the model to get that accuracy is where a larger challenge lies. So my next question sort of pertains to that only. Kanchan, how does the low data regime that you specialize in factor into developing these AI models for healthcare settings, especially where like large annotated data sets are not readily available? How does this work then in training and developing these models?
So there are some technical methods which are like active areas of research in AI to even work with low data regime, and um, like there can be different scenario of low data. Like we could have a lot of images, but it could be difficult to get experts opinion on all of those images, what we call annotation. So like limited annotation is also one of the aspect, or sometimes we might even have very like less data or images or videos in piece of hour itself. So for example, like even if we're right now, like the practically what we're facing is we are we are collecting data by ourselves, but besides that we also have publicly available and other sources of similar kind of data with projects like running on other part of the world. And with access to those data, like there are techniques in like AI which are called like transfer learning or domain adaptation, where we can use a larger data set to build a model, and then we can like use a smaller data set to like adapt model to a new setting, like things like that. So there are different tools, and that's what is all about, like using AI in load data, using like tools like domain adaptation, and then sometimes we might have a lot of unlabeled data and very few labeled data. And in that scenario, like we have techniques like unsupervised learning, self-supervised learning, semi-supervised learning, in which we can learn some pattern out of unannotated, unlabeled data as well, and then we can finally tune our model through limited labeled data sets. So we're using methods like that.
Could you elaborate more on collecting data from different parts of the world? And like, why was there a need to do that? And how did it help your solution get accuracy even better?
Okay, so machine learning and deep learning models we develop now are really data hungry, what we say. So it's good for them to see a lot of data. It's anything we learn, we get better with experience. It's kind of similar with deep learning models. So um, it's very obvious that a lot of diverse data generally makes model better. So that's where the need comes in. We can just train our model in data we have, but there's nothing that stops us to use other data sources that are available, because that would make our model experience and see more examples, and it would be able to generalize more. That's why we're using, and yeah, that's it.
Okay, thank you. Yes, that's very helpful. Moving towards the intervention, Dr. Bishesh, you very thoroughly explained what the model really looks like and how does it work. But could you walk us through how the AI-assisted fetal ultrasound system will really work in this setting, and why AI helps in the scanning process, and how will it help the community health nurses? Um, and then more on that you're collecting data from an urban teaching hospital and also a remote community hospital. So what differences have you observed between these settings, and how has that informed your approach?
Exactly how the system would look like. So there's multiple components, and the within the AI-Sarosh, we're doing one part of it. But in ultrasound and obstetric ultrasound, this domain of this work is of big interest to us, and we have other few projects, other funded projects, and other collaborations which where we focus on other pieces of the puzzle. So it's a big puzzle where we want to solve this in parallel. So when looking from that lens, you can see, so when you have the handheld device, so the system ideally, once this is done, and there are other research groups around the world who are also exploring this problem, trying to solve this problem. So the key idea would be one of the approaches many people have taken is this blind sweep protocol, where non-experts, even non-experts like us who have never used ultrasound, could uh, technically be able to acquire images or the videos within after 5 minutes of training, because it's very simple, taking the probe and getting it in the abdomen and then going through a specific trajectory. So once you have that, if we look at the system in future, ideally we would want first to have an AI model that assures that the quality is good enough of what we have taken, right? Because if there's some mistakes, it should be able to give feedback to the user and then show perhaps diagrammatically, or through the illustration or through figures on the app itself, that okay, this is missing, or you retake this once. So that's what would be a quality control. Although this is not the within the AI service part we are doing, but it's something we are working with other collaborators in other. But this is one component. And once there's a good quality videos that is coming from non-experts, the second would be the analysis or the predictions based on these videos. And this is where we need AI, because it's for humans, it's very hard to measure or to assess these videos, because it's non-traditional. It's not something that is normally done in when radiologists do the scanning, because radiologists, they go to very specific places, to very specific anatomy, by using their years of learning and experience to go to right places. And once they have right image, they do the interpretation. And even there, so for traditional radiologists, or for the traditional approach, we need an expert that can maneuver, that can guide the probe into a right view. So getting the right view and being able to measure correct things in that view, that images, and then do the decision. So there are three things involved. While the approach of blind sweep is okay, we don't have this expert who can do all this, then we allow a very simple way to capture as many videos as possible with a specific protocol, and let AI combine all those difficult information that is spread throughout these different images in many videos to come up with results that matter. For example, gestational age estimation, which is quite important. And there are other work, early evidence from other people's work, which shows that AI model that sees this video, simplified protocol video taken by non-experts, can estimate gestational age, which is as good as radiologists doing it from traditional way. And now people are trying to push that frontier to other metrics like fetal presentation, placenta location, cervix shape, and there are many other different things that are important in monitoring pregnancy. So can we do these things or not? And that's where, from the early evidence, there is promise and there's potential, given the if there's enough information in these videos, although spread and not suitable for humans to analyze, but for AI it could be suitable enough or good enough. And this is why AI is needed in terms of the to reduce the dependence on the experts, which is not available in most cases. This is where, so the system would be, so quality, one would be quality, and the second would be, once the video is taken, it gives these estimates, and estimates of different things that are required. So this would be gestational age, fetal presentation, placenta location, whether it's a single or multiple pregnancy, so depending on which trimester the person is, so all these indicators. And third would be, most likely in a real system, we would could also give why it came up with that result. So a bit of explainability part where, okay, so the areas where it focused on, all these important, so that people hopefully would be able to interpret that better. That might be the third. And fourth, depending on the outcome of this, whether it's normal, abnormal scenarios, the non-expert who's taking the video, they might have to refer, or the health system or the place where this is being done, if there is certain risks or certain things that is not clear, to flag that, and then to recommend the patient to go to the experts. So working in a more triage setting. So this is something that will most likely depend on how exactly this is implemented, and which health systems we are in, which countries' health systems we are in, and how much accurate these systems are when we do the detailed evaluation, detailed validation studies on what is the best approach on how to act on the decision that the AI makes, right? Because then we need the human in the loop to work on this part. So that's the stream on the resource constraint settings. But there are definitely work on trying to build the guidance systems, even for, so that there's someone can be guided to right place and then do the interpretations. But these are in general ultrasound research directions people are taking, or to build something like, from all those videos, we go to build a 3D or 4D video or the image, where you can look later at any slice. So trying to build the whole 3D model of the fetus, or the uterus and the fetus, and then to look at it in a way something similar to MRI or CT scan, where people can look at different slices retrospectively. So this is more reconstruction and compounding, this kind of research people are doing. But then I think in the most practical and most urgent need is to be able to detect life-saving conditions, or to detect life-threatening conditions rather, or important conditions, so that they can be warned or flagged to go to the higher center, so that we can save lives. I think this is the most practical and most urgent need, especially in the resource constraint settings. And the system would be used in that context, I think.
Yeah. Thank you for sharing that. That makes it a lot more simpler because now I understand why there are so many nitty-gritties and details involved in getting these, and how the AI tool will really not just scan, but also analyze and predict. And there are certain factors that's trying to predict. Um, Coming to the data points again, NAMI has been collecting data from an urban teaching hospital and a remote community hospital. And then Kajal also mentioned that there are other sources, there are publicly available data also. What differences do you think that you've observed in urban and remote settings? And how has that informed your approach, especially because this tool is being built for remote and resource constrained settings?
Yeah. So when we say we are using publicly available data, there's very limited actually in this domain, very limited, there's very few, but then there are other which are not exactly technically publicly available yet, but these will be publicly available in the future, I think. But now, for example, we have a Gates Foundation project where Gates Foundation is also investing a lot in this domain, and from through that project we have access to data that had been collected in other parts of the world, in the US, in Africa. And we have another project where we are ourselves collecting data and doing a project with the Gates Foundation on collecting data in Africa, in Pakistan, and in Nepal. So these are new data. And so what's the difference is, I think, so the blind sweep protocol itself, it's a relatively new for in the AI context. Although this was devised, I think, in the early 2010 or the first in the 2000s in the context of telemedicine. The blind sweep protocol itself, it was used. The idea was to do the very simplified protocol to capture the videos and then send it remotely to an expert, and the radiologist look into these videos and interpret. That's where this was initially used or initially invented, and people used it and showed early promise, but it was hard to scale. This is still recent, so people have then the questions was, okay, how many sweeps? When we say the sweep, we need to cover the abdomen, but we cannot take a long period of time with a very complex protocol. So when you start simplifying, is it just 3 sweeps, or is it 6 sweeps, 8 sweeps, 9 sweeps? How many is good enough for which kind of AI models? So this is still in research phase, and multiple groups have tried different groups. We're doing 9 sweep because we want to look into cervix and specific things. Some previously the large amount of data that was collected in the US and Africa, they did 8 sweep, 6 sweep protocol, and certain companies are doing 8 sweep protocols. So these are still evolving, and I think we are building better understanding on how much is enough and how much of this variation in the sweep would impact the AI model's ability to infer and interpret these images. And this is also why it is important to have these data sets from different sources, so that we can do more experiments and build better insight. And in the urban settings, it helps us collect larger data for now, but we still try to simulate remote settings in the sense that we can ask nurses or non-experts to do the data collection with this protocol, right? But the benefit of the hospital, like the higher tertiary center where we do that, is we can collect larger volume because there's a larger volume inflow. In remote settings, it's still technically this almost the same, but the flow is less. And there the importance of having the handheld device, so logistics wise, internet wise, operational wise, so these things also needs to be considered. And the people who typically do the scanning over there, so they have to find this user friendly, as again someone who in the tertiary centers are used to with multiple machines in multiple setups. So there's more human practical aspects that also needs to be considered. But technically in most settings, since we can simulate these technical aspects on both sides, I don't see much difference, at least until now, where we are building this training phase. But indeed, when we do the actual evaluation, we will be doing this in the community settings where these are intended to be deployed in future if successful. So in these settings, we will be comparing the rural obstetric ultrasound governments, this normal approach that they use in rural settings. We will have radiologists go there in these settings and do the scanning. We will also have the AI model with the community health workers or the nurses doing this, and we'll try to compare these three together in realistic settings. So this is the validation or the field testing part that we anticipate doing it later this year, starting towards the end of this year.
I think primarily with the remote and urban settings, I was personally just curious about whether there are trends in the fetal ultrasound services and what the results are coming out. If there are any certain trends that are particular in these settings. But if they're not, that's also another interesting insight that they're not much difference in either urban or remote settings. And that helps because that means that um, the AI tool is for every use per se, and it's not particularly for that because it has been trained on both data sets. Um,
I would say I wouldn't say there's no trends. It's just that we haven't. I mean, we are still doing this in the process, so we will have more information about those differences
okay,
as we collect more data on the community settings.
okay, okay. Thank you. Um, Dr. Bishesh, again, the question is for you. What ethical considerations do you think are guiding your development process, especially when working with maternal health data across different communities in different settings? And what are some challenges that you've faced so far?
Mhm. Yeah, I think one of the most important questions to begin with is why are we doing this in terms of ethics, also whether by achieving what we want to achieve, is it going to improve the outcomes or help the pregnant woman, or it is as against the current situation? And this is what drives us. I think is because it can be a huge, it can play a potentially a very positive impact on the health outcomes. So that's the first part where, I mean, I think that's the first question one needs to ask when we try to do something on human subjects or when we want to do healthcare project, whether it's really for the patients or not. So it's in the end the patient first approach that is extremely important. And after that, I think it's the way we conduct the study. So the consents we have to take with the subjects we need to explain before taking the data. This is what we are doing. This is how we are doing. And then for that, and of course, indeed, in this process, they would have a lot of questions before being convinced to actually do this. And this is the other important part. The other third part would be in terms of the data system, because we collect this data across multiple sites. In another project, we collect across multiple countries. And in these scenarios, anonymizing the data, have going through this due process of not making this public, the personally identifiable information. So these are also important, especially in the future. I mean, eh, not just in future, but even in present, to have these due processes. I think that is quite important for us. So yeah, I think those are the most important thing in terms of ethics. And the fourth would be the to have this because the goal is to make this ultrasound service accessible and affordable to everyone. So when we build these technologies, we ensure that these AI models are fair, so that it works with people in the everywhere, or we know where this model is working and which domain. So it's important to understand that. Try to make it work with in scenarios where these are intended to be worked, and to make this affordable. That's also the other exciting part for us, because these handheld ultrasounds are getting more and more affordable, and if we can build the AI models and then deploy this in a service in a much more affordable way, this becomes accessible. Especially in the settings where we will intend this to be deployed, it's very important that these are affordable also.
Thank you. And especially with the privacy part, like you said, that even collecting data requires a lot of explaining to the patients and to also know that these solutions are essentially for them and not, I know it's all exciting to do research and create these tools, but at the end, the center of the solution is the patients and who they're being designed for. Um, just to go back to your initial days when this project was started, and what have been the learnings so far in just your own guiding process, especially with privacy, especially with inclusion, and how has the journey evolved for you and your team, especially through this project?
Mhm. I think the learnings, there has been multiple, I mean, in multifold learnings, I would say. One aspect was the I think we have started appreciating and realizing more of building capacity on both our side and our clinical partners side on, especially, for example, the data collection itself. We thought, okay, we computed in the beginning when we proposed the idea, we were computing, okay, how many patients come in the hospital daily, and then we were calculating mostly based on that. But then once we started implementing the project, we realized, oh, not all patients would come to the give the consent, and not all the radiologists would be able to do the scanning, and not all the machines are well equipped to have this data transfer, and then this the amount of time we anticipated only the sweep, but then you have to do the filling of the form data. So there's a lot of these blind spots we had in the beginning, which made us uh, make more pragmatic and more practical targets in terms of how big you can collect, what's the process. The other big learning is the capacity building in our team, like Kanchan and other people. On We interact with radiologists, we interact with public health professionals, we interact with nurses, and there's a capacity building on both sides. I think from the AI engineers, AI researchers side, to understand the language of the medical professionals and how they think and what are priorities for them, and for them, for the most of the medical professionals, because I think we are, as an institution, NAAMII, and also as an individual, I think we are the first ones to do many AI projects in Nepal in health. So, and it has, we have seen is the tremendous capacity building in the health, in the hospitals, and the health professionals who are involved with us, who initially for AI is a new thing, and then bit perhaps concerned or not sure how this would be used, and then to uh, thinking of this something as something very hard or difficult to do, but going through the process to understand what it takes to do, what are important things. And for them also, I think there's been a lot of capacity building, and now we can see new ideas, they're suggesting new ideas, new projects, and maybe AI can help here or AI can help there. So this is something of a bigger learning in terms of the what was the other last, specifically on the learning, specifically to what you wanted to ask? Sorry, I missed that.
Yeah, for your team primarily, and how has your just solution in been more informed with time? Like you stated that there is capacity building for the team in general, and then like opening different routes just to understand how this one project can help other projects also build up, or other projects can help this project build up. And just like you said, you now when communicating with hospitals and learning about data, there are challenges in terms of how to explain them and also explain the whole team on how readily accessible we can make this, or how can this inform, because it can't work in silos. You have to go to hospitals, get data, and there's a lot of convincing from their end as well, because it's mostly the debate is around AI versus humans. So just in low and middle income countries, there's always a threat to this. So learning through the process for your teams, and I think you've answered that very nicely. But if you have anything to add to that, please do.
No, I think that's, yeah, we covered what we wanted to say. Thank you.
Okay, thank you. Kanchan, explainability is a primary focus area for you in AI development. Um, Can you please explain how the team, how NAMI, and your contribution in making the AI systems and their decisions more understandable to healthcare workers who may not have technical backgrounds, because we're working with non-experts here. Yeah.
So, like typically while building AI models, we give AI models the input and what the output is supposed to be, and like during like in getting trained, AI model is supposed to figure out the pattern to map input to output, right? So, like we might not always know what AI model like is finding out as pattern, but there are some technical tools like to like visually see on like when we talk about images, like we're mostly working on images right now. So on images to see what part of like image is the model focusing more to extract those pattern and like that sort of thing. So what we're doing right now is like we're building tools to like find like those reasons and like since this is a new thing and even clinicians are not used to like interpreting these blind sweep videos, we have like repeated discussions with them on like also for like prediction of this task, like how and what pattern would you like focus on this like sweep versus what the model we built is focusing on, and then like we try to explain them like it might be this, and sometimes even the like doctors like see us that the AI might have picked this thing, and maybe we can try on our end also to see if we can like observe this thing compared to what we have been traditionally doing and things like that. So that's what we're doing right now.
Thank you. Thank you for explaining that. It's such a new domain for me as well, and it just helps to understand how the AI model actually works. Um, and especially for people who are not experts in this. I am just really looking forward to this. Dr. Vishesh, once this project is successful and the AI model is developed, how do you think it would impact the future of maternal health care, especially in rural Nepal? And do you see applications like this for similar regions across South Asia? And for that to ever happen, what policy or infrastructural support would be needed to scale the solution beyond its pilot phase right now?
Mhm. Yeah, I think if in the pilot evaluation, we can show that if we observe when we are designing a study where we want to compare this approach with AI that we built with the handle device and a non-expert in community, that versus existing rural obstetric ultrasound program that the government is already deploying in many places in rural areas, versus if radiologists were available. So there's three different things that we want to compare. And based on this, I think the promise then the second phase would be a larger validation across different. And because we have multiple projects on ultrasound, multiple fundings coming together, we are working with the teams in Africa, in Pakistan, and we know that this is, and there are other teams independently working in other places. So there's clear demand, and the importance of this work is clearly outside Nepal. So that's not, I think that's clearly well established already. Now the question is country wise, how does this get implemented? And we can see there's some variations on how the obstetric programs are run in different countries. For example, in our case, rural obstetric ultrasound from the government, the nurses are involved. In Uganda or in certain countries in Africa, there are midwives who are involved, right? So these are, so there are different forms of non-experts who are involved. And for me, I think the pathway to deploy this is what we are now already starting in the second phase of the AI-Sarosh project, is to engage with the government, who are now our partners on this who were doing the rural obstetric ultrasound program. They will be working with us on this initial pilot study phase already. So from there, trying to engage them, getting their input, getting their insights built into our systems and solution. I think it's one of the important steps for us towards the integration in future in the national programs, national health programs, where the other pathways could be, for example, in tuberculosis, we know that the World Health Organization, they officially put in the TB guideline, tuberculosis guideline, the X-ray trials of tuberculosis with the AI X-ray, AI algorithms for X-ray. This is in the recommendations, right? But this comes after certain evidence. So building models that are robust, then building the evidence base, and then doing the policy changes. These are the chronological pathways, but we can already start engaging with the people so that we can take them as the co-creators of this kind of systems, and accelerate those paths, I think. this is how it will go. And there's some variations, but in most countries, in low-income countries, there is community settings, antenatal care, where certain non-experts go visit to the pregnant women or families and then do the scanning or do other forms. So augmenting this scanning, I think it's a natural extension to the existing system. So we don't see much barrier in that, but perhaps something that needs also to be become more clear is the frameworks, regulatory frameworks that are not well established in these kind of countries. How do we build those so that these things get integrated into the system? So that's something also to tackle, I think, in the near future.
Thank you. Yes, I think with AI solutions, it's very important to have regulatory frameworks. They're not there's more research happening for AI, but there's not a lot of research happening right now to evaluate these AI models, especially because it's still new, it's new research happening. Um,
Yeah,
the next
sorry,
question,
one thing to add in the last question is
yes,
also, and
please.
I think it's something I have been raising in multiple forums, is also lot of the times people don't think about this aspect is also the health economic or economical aspects. Affordability, as I said earlier, it's important. So who gets to build and deploy these kind of systems? And if it's in, especially for one or two products, that's fine. But if for a country, low middle income countries, if all the health related AI services and AI products are to be imported, I think the health system will get strained a lot in terms of economics, and it might not be as affordable as it would be, because by design, by the, I mean, in general, the situation for most low income countries, already they have a big trade deficit. That means there's big export and very few import, and then the economic is not that great in most of these countries. In general, not just AI, but in general, of when we look at the big economy in general sense. And now AI in healthcare and many other domains, as it comes in the next decade and next 2 decades, there will be a lot of transformations. But this is the AI for good that we are doing. Of course, AI has the potential, but if this is not aligned well with the economic model, where these countries can sustain this, can adopt this kind, or the take these systems and deploy in their deploy, it's tricky. So, and that's why the capacity building in low-income countries, where they can produce at least some of these models or the products, so that there is a more equitable landscape in terms of the import and export of these technologies. I think that's also important, but it's a much bigger discussion. Maybe it's not so crucial for one individual product or two particular products when we look into it individual sense. But when we look at a bigger scheme of things, where there will potentially be many AI services and products coming in the countries, at the country level, they will help. For example, the ministry will need some budget. From where do they get that budget? And if it's amplifying the trade deficit that's already exists, they would be already struggling, and this won't work, right? So these are also other barriers one needs to think of when building these kind of technologies, to how to create a more equitable world where low-income countries are also producers of these technologies and not just the consumers.
That's a very important point, and especially because from what I've noticed in Pakistan specifically, a lot of these rural healthcare settings are already struggling with a lot of funding opportunities. And then if we bring AI development products and they're only available at private uh, hospitals or private facilities, then that's not really accessible or equitable in the first place. So to equip rural settings and rural hospitals and basic healthcare units with these services. Funding is a great question. And local capacity building and local manufacturers and local development of these AI tools is the solution. So thank you so much for highlighting that. Economics is a great concern. Just a last question on what other services beyond fetal ultrasound, what are other areas in maternal and reproductive health, or even beyond that, that you see as promising for AI applications in resource constrained settings?
Yeah. So we do so at two scales, I would say. So one is the transforming global health with AI. That's the research group we have within NAAMII. But NAAMII itself has other many research groups and working in other AI projects or research beyond healthcare also. But from within the healthcare in Togai, which is our lab within NAAMII in the group, we work on many different problems. But there is a strong focus also in sexual reproductive maternal health. Like Kanchan was also working and was still working on cervical cancer, for example. That was one of the first projects Kanchan worked with me, where we are building this AI-assisted screening tool based on smartphone, low cost, very simplified protocol where any smartphone could be used to screen the visually inspect cervical cancer. That's the one project. The other, smartphone microscopy. So these are low cost devices. So instead of going to details of each project, I would say the whole theme of our research is on how to broaden the scope of health services and how to improve the quality of health services in rural and community health centers without putting more strain or without the need for adding more manpower. So existing same health professionals who are already there, how do you augment them with AI so that we can broaden and we can do many different diseases, screen those or do early detection of those diseases and provide services that are not available now, or improve the quality of services that are already existing, so that because the community health is the foundations of these public health systems in most of the countries, in especially in countries like Nepal. So that's the key focus where we work on different health problems. And the other is to reduce the burden or improve the quality in the tertiary centers, because typically what happens is the tertiary centers, the big major hospitals, the people from all over the country come, and then it's because it's affordable and then it's better care. But then since so many people come, it's very hard for doctors and medical professionals to keep up with this huge load of patients. And how do we streamline processes? How do we save experts time by introducing AI? So that's the other theme where we work in terms of our group. But other groups are working on many other stuffs. Even we ourselves also do the theoretical research and pushing the frontiers of AI, because many of the times the existing AI solutions, they don't work well on the things that we want to solve. So we need to build new methods, push the boundaries. So these are the things we are doing in our work. And it's not just about knowledge generation, as I said earlier, about the importance of translating this into a real product and building capacity locally to be able to build products. We have industry innovation division where we strongly collaborate with industries on one side, and other side we incubate startups and help build startup companies that can get spin off at one point of time by translating this knowledge, generated knowledge, into products, and hopefully also being able successful commercially so that they can bring back money, and then we have a more self-sustaining model, and while meanwhile also contributing back to the economy. That's the economy. Yeah.
Thank you, Dr. Vishesh. Another interesting thing that I have seen about NAMI is the annual AI school. Um, could you just briefly tell everyone who's watching right now about what the school is about and what does it teach, and who is it really for, and just more details about how it emerged for NAMI?
The AI school, it's part of the also the bigger vision at NAMI we have, where we are trying to build an ecosystem in low resource countries, countries where these excellence ecosystem isn't available. How do we build an excellence ecosystem? And that requires three crucial elements. One is the knowledge generation, ability to generate new knowledge. So that's research division, where we have different research groups working on different problems. That's one division. The second is, once you build this knowledge or this latest knowledge that is there, we need to disseminate. We need to build capacity by training next generation of people so that they can work and also are ready to build new knowledge. So that's education outreach division, where we work from people across many different domains and different age groups to build AI capacity. So this is not just healthcare again, because NAMI works on overall AI ecosystem and what we call as we have AI native. So how do we build people who are AI native in the future decade? How do we prepare them? How do we give foundational skills, and how do we give deep skills on AI? So this is the education outreach division's goal, where we do these kind of things. And the translation with the industry innovation division, where we translate knowledge into innovation and commercialization, so that the value of the benefits of AI, benefits of science reaches to the people, while also ensuring economic viability. So that's Industry Innovation Division. So now coming back to the AI school, we started that in 2018. December, which I think because most of us, our team who started this, we had been trained in Europe, most of us, and some of us in the US, and we have seen summer schools, AI top schools for a few days happening, where a lot of people from around the world come and get to learn from really amazing speakers from also coming from around the world. And we didn't see that happening much in Southeast Asia, and we wanted to build this as this annual school where people can come from around the different countries and regions to come together for 10, 11 days of intensive course in AI, where we build from the foundations to advanced applications with 10 days and 1 day of hiking, because again, Nepal, we have lots of hiking places, right? So it's a mix of getting to opportunity to come together, do a lot of networking while learning, and also have and this is how we started, and we have been doing this for last 5 years now. Sixth edition will be in this December, I think. So it's usually in the December, we say winter school, and we typically have 150 to 200 participants every year, coming from 20, 25 countries from around the world. Typically, this is useful for senior undergrads who have some experience in AI, or even PhD students of certain domains who want to get into AI, and the professionals, working professionals, software engineers, or AI engineers who want to level up their expertise, because we get speakers and scientists, professors coming from really different places, many of them coming from top research labs around the world, 30, 20, 25, 30 speakers together with 150 to 200 people. It's like a festival. And I think this is one of the biggest on-site and longest school in South Asia. And I hope to this, many people who are listening to this in South Asia would be able to apply and hopefully come also in this year's Annual Nepal AI School, which is NAAMII.
Thank you. Thank you for sharing that. I think it's an excellent opportunity for anyone looking into AI. And even I was very interested when I was looking at the school and all the courses and all the whole curriculum that it sort of offers. Um, Thank you so much, Dr. Bishesh and Kanchan, not just for your time, but also sharing, valuable insights on how AI can really transform not just maternal healthcare, but generally overall healthcare delivery in resource constrained settings. Um, just talking to both of you reminds everyone that AI's true potential is not really in replacing human care, but sort of extending and making healthcare more accessible to people who really need it, and to also empower community health workers with these tools and projects like yours that sort of reimagine what is possible. Accessible fetal ultrasound services are possible, and they're getting possible through AI use and AI assisted use. Um, so thank you so much for your time, for sharing your knowledge, for sharing your experiences and learnings with us. We will be continuing our Inside the Project series with AI-Sarosh. And whoever is watching right now, we invite all of you to stay connected, learn from each other, contact our grantees if you have any collaborative opportunities, and join this growing community of practice that is dedicated to ethically and locally responsive AI solutions. Thank you, both of you, for joining. And thank you, everyone who's watching right now. Um, Take care, and we'll see you soon in the next episode.
Thank you. Bye.
Thank you. Bye.